please bear with me. I have this habit of eating my words, so you can stop me later or even when I'm speaking. I certainly welcome involvement of every kind. I'm here today to talk about sustaining a healthcare Focused NGO. But the fact is, we were not established as an NGO. Impact was established. Impact was a response to United Nations General Assembly resolution to address the problem of the growing disabled in the world. This was in the early 1980s. Mrs. Indira Gandhi was present at that General Assembly resolution and accepted this invitation to be the first country to do something about disability. She came to India and met the House of Tata. And to cut a long story short, it was through Voltas, a Tata company, that Impact was formed. Impact was launched by the Government of India on the 2nd of October 1983 to act as a catalyst to bring together NGOs, corporates, professionals, the community, and professionals to work on the problem of reduction of disability. We actually commenced with the prevention program, with immunization. This was way back, again, in the mid-80s. We did a program in Madras, polio-free Madras. And this was in 1986, which is recognized by UNICEF as being very successful for that particular city. The success of that program was replicated in Bhavnagar and in Mumbai. We laid the foundation for the polio immunization system in the country. But it took as long as it did till a couple of years ago for polio to actually be eradicated from this country. We don't yet know whether it has been eradicated. But we say that it doesn't exist here anymore. Why I'm emphasizing that is because at that time, we were a response. When we started in response to a pressing need. As much as I heard people say it here today. Many people have said that. So we were just one who responded. And we were established from the very beginning to work with the government. To be that catalyst. So we have no option. That is our mandate. Currently, Impact India has two major projects. The Lifeline Express hospital train. How many of you have heard of the Lifeline Express? I'd like to know. So there are quite a few, a handful. Obviously you have, Dr. Desai. But how many people have not heard of the Lifeline Express hospital train? Most of you haven't. So this is India and the world's first hospital on a train, which was started in 1991. So to go back to our story, after we completed prevention programs in the urban metros, we said we have to look at rural India. That is where access is a problem. Many of you stressed and emphasized that today as well. Access is a problem in rural India. The poor can't afford to come to the city where there are hospitals. So we needed to go to the rural poor. We initially started with mobile medical vans, and it was at one such camp in the foothills of the Himalayas that we heard the horn of a passing train and thought to ourselves, India has one of the largest rail networks in the world. Why aren't we using it? In short, we landed up at the doorsteps of George Fernandes, the railway minister at that time, and said, we want to train. Of course, he laughed. You want to train? Why? We said, well, it will be a very good PR for the railways, you know. If this is your humanitarian, this is your way to give back to the society, if you have a hospital on a train. And again, to cut a long story short, our founder director at that time was the first lady president of the International Public Relations Association, Zelma Lazarus. She's 80 years old, she still comes to work. She went around and raised funds all across the world, including from the Rotary Clubs of Great Britain and Ireland, to equip this old wooden coaches that Mr. George Fernandes had given us. In 2007, we were given brand new coaches. And today, we have a 5-coach train. It's been 170 projects, 130 districts, 20 states across India, and already served 1 million disabled. This is your project. The Lifeline Express belongs to you. When we talk about scale, it's been replicated by 4 Lifeline Express trains in China. Fellow Peppers, South Africa's 2 hospital trains are inspired by India's Lifeline Express. Jibantori has a floating hospital. Bangladesh has a floating hospital called Jibantori, where surgeries are performed, inspired by Lifeline Express. Cambodia has leg clinics, and many other people have different kinds of now vehicles to be able to bring rural hospital facilities to the rural poor. So it's already reached the scale. But India, we still have that one train. And even though we've had conversations with the governments of Chhattisgarh and the governments of Maharashtra to replicate this project so that the poor of their area can access it, nothing has materialized. And in a way, we don't wish for it. We wish for the day when the train becomes redundant. Because then, players like you and everybody in this room would have done their best to be able to refurbish the existing hospitals so that the rural poor can actually access them. We do engage with the government. We have signed an MOU for each project, each halt with the Ministry of Railways. The District Health Administration is part of the project. Our specialists are sourced from metros. There are very few specialists, as you know, who are willing to serve in the rural areas. But our specialists come and donate their time. The follow-up is done by the district level medical staff. We engage with them. In the old days, we would have our patients inside a tent or a shamiana. Today, we're very conscious that all our patients, after surgery on the train, it has 2 operation theatres with 3 tables. Post-surgery, all the patients are moved into a rural hospital. While we're looking at cure through the Lifeline Express, we haven't forgotten the mandate of prevention. Many of you again have brought up the fact that prevention is the way to go. It's less expensive. So we have a model project in Thane district, Maharashtra, a community health initiative where we're looking at prevention of disabilities. Along the way, we discovered that we take care of RMNCHA, Ramancha, that at least congenital disabilities could be taken care of. Subsequently, we have refined our model to look at adolescents because it gives you that much leeway of time to change behavior change communication when you address adolescents than when you work with mothers who are already pregnant. Lifeline Express, as I've already mentioned to you, this is your train. 5 coaches are there today. 2 more coaches are being customized at Perambur, Tamil Nadu, Integrated Coach Factory, to do cancer detection as well as general surgeries for hernia, hydrocele, birth control, very vital for our country. Prevention of stroke. Already, we are doing cataracts, we're doing hearing impairment, we're doing cleft lips, orthopedic, polio correction, clubfoot correction, dentistry, epilepsy, and also training of ashas, community workers, oral health hygiene. All this is happening. We utilize the train to its fullest. On an average, 6,000 patients at each stop. At least 1,000 surgeries at each stop. As I mentioned to you earlier, all the specialists come in team and donate their skills. They don't charge us anything. We pay for their travel. We pay for their accommodation. When I say we, it's not Impact India Foundation. We're registered as a charitable trust. So we cannot fund, but we can raise funds. So we get the corporates to come and sponsor. We get foundations to come and sponsor each project. And they pay for all of these. They pay for the medicines and everything. Patients care as well. So here we're not just touching lives, we are transforming lives. The Community Health Initiative is a preventive project. This, again, we work with the government. Everybody has sort of said it's very hard to work with the government. It is a challenge. Of course it's a challenge, but we at Impact India are not giving up. To work with the government is the only way to scale. They have the infrastructure, they have the manpower. What we do is we train the government health staff. We train, and it isn't easy. So you have to get the proper permissions in place. So we have an MOU signed with the CEO of the Zilla Parishad in Thane district. So that the ASHA, Anganwadi worker, A&M attend our training sessions. And today the kind of interventions that we are doing with adolescent girls, they will do tomorrow. Some of our interventions they've already internalized and they've mandated it. So there's a coordination committee that is formed at the district level comprising different departments of the district and block level. ICDS, health, tribal department, and so on. Two vital pillars of sustainability of this project are training of government health staff, and the second is community empowerment. Unless there is a demand from the community, how will things sustain? Tomorrow, Impact India, which is going to be there for a short while, 2 years in each PHC area, will disappear. So we have to prepare the community. And these are tribal communities who are reclusive. In the first place, they couldn't come forward. They wouldn't understand what health and nutrition education is about. So we brought in the train as many as 7 times to build their confidence. The train presents a very good, clear picture of before and after scenario. Before, I couldn't see, now I can see. Before I couldn't hear, now I can hear. Through word of mouth, we've actually won the confidence of the people, and they attend their health and nutrition sessions. Home deliveries have gone down. Institutional deliveries have gone up. We're on our way to lowering the MMR rates. Embrace Nest. I think there's an organization in Bangalore and Karnataka that gave us this portable incubator. It was given to us through Johnson & Johnson to try it out. It is so successful that the state government has now taken it up. UNICEF wants to scale up the use of this incubator. So we are a platform. We are a platform for people like you who innovate, because this is where rural India is. So both through our train as well as through our community health initiative, which is today in Thane district, but tomorrow it will be wherever we are. Wherever there is a need, sorry. I would like to end by saying that today we are absolutely impassioned by adolescent anemia. I ask you, there are 113 million adolescent girls in this country, aged 11 to 19 years old. 56% of them are anemic. What are we doing? What does this mean? What does this mean? It means hindered growth and development, irregular menstrual cycles, inability to concentrate, compromised education, dropping out of school, early marriage, obstetric problems because of anemia, because of low BMI, low birth weight children, mortality, death. Somebody said here the first speaker that I met today, I came late, said here that in our country, death is regarded as very cheap. We need to hang ourselves in shame, because that's a human rights problem. To have someone die and to sit here in the cities while our rural areas are without medical services, and no one is looking at this huge invisible problem of adolescent anemia, simply because it is invisible. We got together with the international organizations and managed to rid our country of a very visible illness, polio. Can we not do the same for anemia? India has the largest percentage of youth in the world. Largest percentage of people under the age of 25. But I ask you, they are your workforce for your Make in India. They are your potential manpower. But if most of them are born to anemic mothers, born of low birth weight, what is the quality of that manpower? It's time we woke up. This is a wake-up call that we need to combine our energies to do something to tackle the problem of adolescent anemia. Thank you. What happened? We jumped. That's it. Nobody seems to look at them. And that will be the result if we do. Thank you.
Hello, ma'am. I am Raghu, representing Sakra World Hospital. First of all, I thank healthcare executive team for picking you as a speaker, and of course with the other senior members here. My question here is, everyone who spoke about the difficulty or the turbulence which they are facing with the government. And we have most of the senior leaders, senior-most people heading the organizations here. So it's a question for them and to you also. How do we, a youngster who's just budding in the healthcare industry, come out of these difficulties? Should we have a platform where we can talk to the government? Do we have anything like that?
I think you create your own platforms. It comes from the depth of your conviction. From the depth of your realization that only they have the scale and the manpower. You begin to develop patience. We've knocked on doors. We've been to the Tribal Development Secretary in Maharashtra to say we want to work in the tribal areas. He literally says, we don't need you. We waited for him to be transferred. We went again. But that is the story in India. Yeah.
Hats off to your patience, and hope we all develop, and we will definitely try to put our best.
Yes.
We all know that iodine was deficient and iodized. That salt is something which everybody would use. It's just a thought where you could add up, I mean, you can go forward with it, with every salt packet if your anemia preparations are strapped to it. Like we have free space given with everything. Maybe an anemia tablet with your iron packet would take it to these masses with anemia is a major concern.
Thank you for your suggestion. We advocate Tata salt, Tata iodized salt. Not because we emanated out of Tata, because that is one of
Exactly. It has reached every nook and corner, and goiter has come down. So maybe this also would.
So we highlight the mental retardation. Explain. There's nothing that people won't do if you explain to the patient.
Exactly.
Once they've earned you. So we go around. We have a staff of about 50 people. 13 of them on the train, mainly operation theatre assistants, and 15 of them in the community health initiative, and they wear blue caps, so they're known as the blue cap doctors. They're not doctors. There's only one doctor. The project director is a doctor. All the others are local agents. They're grassroots people, 10th, 12th standard pass, whom we recruited and taught. And they've become community leaders and influenced the community around them. There's one more thing I'd just like to say which I skipped. Impact is the first flagship of 13 impact foundations around the world. Impact India was first to respond to that General Assembly resolution. But today there's Impact East Africa, and ENT doctor is the person leading that team. So each of the impact organizations around the world have developed their own objective of reducing disability, approaching it in different ways. Impact Philippines has a nutritionist at the head, Dr. Florentino Salon. So he's approaching disability that way. And we have learned from him to approach our adolescents in nutrition program. Impact Bangladesh, I mentioned, has a floating hospital which does surgeries. They also do nutrition programs. Impact Nepal, Impact Pakistan, and so on. Yes?
Just a question, like, if left to you, how many such trains do you think India needs?
Every state needs a train. If left to me. But that's not the way to go.
This would be 29 each state.
But that's not the way to go.
How
I think
many you have?
we have 5 coaches, 2 more to come. It's booked every month, and now with the CSR, mandate of spending your 2% net profit, it gets, particularly at the year end, like this financial year end, people say, we want to train. It's a very good opportunity for employee engagement, good opportunity for branding. Mahindra's has produced a coffee table book, 15 Lifeline Express projects, a brilliant big coffee table book they produced. They have something called ESOPs, which is to do with employee engagement. They have used the opportunity to call the governor of the state for the inauguration, the chief minister for the valedictory ceremony, press conferences and so on. So yeah, but still to come back to your question, I still say that it's not the train that we need. We need to put in that special manpower, that effort. Do not give up on the government. Do not give up on the rural hospitals. Work side by side. They are men like you and me, women like you and me. We can train the nurses, Anganwadi workers. We can also work and inspire the doctors. We can do it together. Yeah. Sorry? Absolutely. You can use it as the ambassador to get into the area. Most people do. Sir, I'm waiting for you.
Yes, I think what the need of the hour is we are a large network. I would formally invite you to our hospital to give a talk to our doctors about how they can help you, and we have a network. I think you need to come and talk to some of the people in the corporate sector. What I said in the morning, the physicians, there are a lot of people who want to do a lot of things. I never knew this existed. So if you could begin with our institute, and I'm sure you can look for cooperation from the government. But there are a lot of people out there who want to help, but we don't know. And I'm thankful that here, this is the first time I heard about this, and it's very moving that we are sitting in our ivory towers, not really knowing what's going on. And the beginning is if you come to us and at least create the awareness, I'm sure the corporate sector will back you. You continue your work with the government, but at least we do not have to go through that level of red tape. This is an open offer for you to come across.
We'll do whatever we can. We are committed to rural India. Yeah. Yes,
My name is Sunil Chandy. I'm from CMC Vellore, and what you spoke resonates with what our mission is in our hospital. Actually, what you said is very inspiring, and we ought to be ashamed that 69 years after independence, we are still talking about anemia in children. It's a simple problem. I don't know why it's taking us so long. Why should we be sitting here brainstorming this simple thing? But I have a suggestion that it's not just the doctors and nurses who are resource people. I want to say and submit that the life skills and health consciousness should be also in the domain of primary education, secondary education in schools. The teachers must talk to their girl students about anemia, how it presents and what can be done. It's a simple preventive intervention. Unfortunately, our education is also so corrupted and so deviated from life skills and what it takes to become a human being. They are filling them with mathematics and information technology and not talking to them about simple brushing your teeth or taking care of your health. So would you add that on to say that one dimension of this is to educate, first of all, the children through schools, and it should start with class 4 and maybe even go up to class 12.
Sir, as I told you, I'm not a very good speaker, so there's so many elements of what we are doing have been left out. We've begun this in Thane district, and in a remote area on the border of Gujarat and Maharashtra, a PHC called Sakarsheth. We are already teaching 3,000 girls and an equal number of boys, aged 10 to 19, on health and nutrition education. And for the very first time, even addressing things like puberty, menstruation, safe sex, homosexuality. It's very important. We're looking at it through the medical lens. We're not judging their behavior. The important thing is they don't have a platform. Nobody talks about these aspects. And in the rural area, you don't even have access to internet, let alone electricity. So, then you have STDs. So it's important to be able to communicate all of this. And at the same time, we're talking about the cultivation of kitchen gardens. How long are we going to keep people dependent on IFA tablets or iron sucrose injections? So we have to teach them how to eat right. Eat right. That's right. Eat right. The problem is they eat a lot of rice with this much of dal and this much of sabji. So that balance, that dietary change has to be also communicated.